Good morning, buenos dias, and thank you for joining this important town hall hosted by the National Hispanic Medical Association, NHMA. Today, we address the critical and unfortunate topic of treating and preventing measles, a disease that was once nearly eradicated but has made a troubling resurgence. NHMA is deeply invested in this issue because our members and the communities we serve have reached out for guidance and information. My name is Rafael Sainz, and I have the privilege of serving as NHMA's Executive Director. I am a pharmacist by training and have been working in the healthcare space for about 30 years. It is my honor to facilitate today's discussion with two distinguished experts in the field. Both of our guest speakers are esteemed members of NHMA's National Immunization Advisory Council, a group of renowned experts who provide guidance on immunization issues and help shape NHMA's program. Joining us today are Dr. Jaime Fergie, Director of Pediatric Infectious Disease and Hospital Epidemiologist at Driscoll Children's Hospital in Corpus Christi, Texas. Dr. Fergie will provide insights into pediatric patient care. And Dr. Susan Gaeta, Associate Professor in the Department of Emergency Medicine at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Gaeta will offer perspectives on caring for adults and immunocompromised patients. Before we begin, let's go over a few housekeeping items. Our speakers are guests of NHMA, and this is a space for learning. Please be respectful of all perspectives shared. We will take questions from attendees after approximately 40 minutes. If you have a question, please raise your hand and I will call on you in order. You may also submit questions via the chat box. NHMA staff will be monitoring the chat and will feed me questions during the Q&A segment. The discussion will follow an interview-style format with both of our guest speakers given the opportunity to respond to each question in English, but we will take Spanish questions at the end if some of you prefer. We recognize that many medical professionals will recognize the sound behind me, but we understand that many of you are medical professionals and you're in attendance. Your input is valuable and we welcome contributions, but we ask that comments be kept brief to allow time for discussion. So let's start by first painting a picture of the current measles landscape. Nationwide, cases have risen to nearly 164, with incidents reported in Texas, Rhode Island, New York, New Mexico, New Jersey, Kentucky, Georgia, California, Alaska, and Washington State. The largest outbreak is centered in Texas, with 32 hospitalizations and 1 fatality involving an unvaccinated school-aged child. According to the Texas Department of Public Health, cases surged to 158 over the weekend in Texas alone. So let's turn to our first expert, Dr. Fergie. As a pediatric specialist, the age distribution of those affected is disproportionately skewed towards children under 19 years of age, making up 82% of cases, with the remainder being adults. What is happening? Why is measles disproportionately affecting children, and what makes them particularly vulnerable?
Well, thank you, Dr. Sainz. First of all, I want to say it's a real pleasure to be here with all of you to talk about a subject that is important and a subject we should not be talking about, unfortunately, but we have to. This is completely preventable. And why the children? Well, when you look at the information from Texas Department of Health Services, you see that the majority of those are unvaccinated. So they come from a community in which they do not vaccinate. And so it is a tremendous risk. And I think that most of the people, the older, adults, most of them are in general vaccinated. And the issue we are experiencing, and all of you who are listening to me, I'm sure you experience the same thing in your practice, the issue of vaccine hesitancy. And we are dealing with this and more. So the younger children, to begin with, the vaccine you give the first dose at 12 months of age, 12 to 15 months of age. So younger than that, they don't get the vaccine. They get the protection from maternally acquired antibodies that they may not be long lasting for that time. And then again, it's just an issue of not being protected, being in close community. And this, of course, the risk is that in the state of Texas, there are areas all over the state in which the vaccination rates are low. Here I am in Corpus Christi. We have overall a good vaccination rate. However, I look at school district by school district, and there are some school districts that are below, not only below 95%, they're below 90%, some of them 87%. So tremendous risk for the children. And of course, tragically, we've already seen 1 death.
Thank you very much, Dr. Fergie. I'm going to exercise a little bit of executive privilege here Is there something NHMA could be doing to help spread the message of vaccination schedules and help our communities get vaccinated?
Well, we certainly, it's a large effort by everybody, and we need to reassure our community that these vaccines are safe and effective. And we need to counteract any myth, any misconceptions. And sometimes what I tell the people, let's just talk to grandparents.
Yeah.
Talk to the people who really experienced this before the vaccines, how bad it was. And people forget, of course, we need to remind them that this is not a mild illness. Children get very sick with this. That unfortunately, about 600 children die a year before the vaccine, and thousands were hospitalized and developed 6% developed pneumonia, and 1 in 1,000 developed brain encephalitis.
Yeah.
So yeah, I think it's a difficult task. We're dealing with it for a long time, but we need to continue educating our families about the importance of vaccinating, not only against measles and using the MMR vaccine, but against all vaccine preventable illnesses.
Thank you very much, Dr. Fergie. Dr. Gaeta, let me turn to you now. Who are our most at-risk adults, and should they consider getting vaccinated?
So thanks for the question. But before I answer that, I just want to reiterate that what Dr. Fergie said is it's very important that the children get vaccinated because now transitioning to adults. If the children are not vaccinated and they go see abuelita and abuelita has, unfortunately, she has leukemia, well, she's immunocompromised. And so then she's at risk. And so I focus on cancer patients, but if you take just a patient who is immunocompromised, which in the Latino community, unfortunately, diabetes is common in our community. So you could say that they're immunocompromised. So it's very important that patients who are immunocompromised, cancer, diabetes, lupus, or other different illness, what puts their immune system at risk for getting measles. And so again, if the children get vaccinated, we'll decrease that risk. We used to rely on herd immunity, which meant that if not greater than 95% got vaccinated, then you would get herd immunity. Unfortunately, as Dr. Fergie mentioned, vaccination rates are less for a lot of various reasons, which we can't go into right now, which puts at risk our populations in the adult community.
Wonderful. I'm glad you mentioned the visits to abuelita. I know when I was growing up, sarampion was always a major concern of my abuelita. So, Dr. Fergie, let's talk now about misconceptions, as you said. Misinformation about vaccines is at the heart of this epidemic. How can we, as healthcare professionals and those who work with the community, combat this? What's the best path to take for informing our Hispanic community?
Yeah. So first of all, we need to tell them clearly that we believe that the vaccines are safe and the vaccine is effective. You know what you tell them is, okay, I have 4 children. They are fully vaccinated. I give every single vaccine that is available because I want to protect them, and you want to do the same for your patient, for your children. So it is important. We can, depending on the level of question, we certainly need to listen to the family's questions and without dismissing them, listening to the question, reassuring them about the process and the years that it takes to develop a vaccine, to bring it to the market in a way, to bring it to the patients, how many levels of studies there are, the multiple phases, how carefully this is done, how carefully it is evaluated, how we even continue to monitor for the safety of vaccines once they are approved and in use. We have mechanism in the country that will allow us to see if there's any problem with vaccine. So with the MMR vaccine, that's a vaccine that, of course, you all know is the vaccine that protects against measles, mumps, rubella. We have decades of experience with this vaccine. And we know they are very safe. We know what the side effects are. Of course, we know that some children are going to develop fever and a rash 5 to 12 days after the vaccine. That sort of thing we do know. Well, so we need to explain this. But I would say, what can we do is social interaction using mass media, communication with our team. Everybody who worked in an office, in a hospital, have to be in favor, have to be a pro-vaccine person. So there are many things that we can do. I think what we're doing right now, of course, is important. But I think what we do then later on with our patients, their reassurance, the way we speak to them, to our patients, we have to be very clear when we recommend a vaccine. For example, I strongly recommend your child get these vaccines today. We shouldn't say, think about it. We say, I want you to get your child to get this vaccine today. These shots are very important to protect him or her from serious disease. Or I believe in vaccines so strongly that I vaccinated my own children on the schedule. My office has given thousands of doses of vaccine, and we have never seen a serious reaction. So that sort of language may be important. The so-called presumptive approach. The presumptive approach meaning that you presume the family is going to want to vaccinate their child. That is, I think, a very important way to approach this, the presumptive, so that we assume that they want to get the vaccine, and not, for example, not to say, what do you want to do about shots? That, for example, or do you want to think about it, or go home and think about it? That will decrease the uptake of vaccine. So I will leave it at that right now and listen to Dr. Gaeta's opinion on this point.
Gaeta?
So what I would say is we need to meet the patient, the family member where they're at. And I know Dr. Fergie mentioned that. And, taking back from the lessons we learned from COVID, I remember I had one of my staff come to me and she's like, oh, you're really into favor for COVID vaccine. Why? And so before I answered that question, I asked her, tell me what you're concerned about. So ask them. And then also use our community health workers, our promotoras. And then the thing that I really want to mention is, unfortunately, with the state of affairs, our immigrant population. I'm Latina. My father is immigrant. He came from Mexico, during the Braceros area. And so now we've had that other mix in there that people are going to be concerned to go to Dr. Fergie, come to the emergency room because they might get deported, the mixed class on there. So we need to now go to where the family are. I mean, it's terrible to say, but we might have to go to the fields and, talk to them, or to that trusted individual who they, believe, again, I use abuelita, people will listen to abuelita. So, go talk to abuelita, educate her, see where she's at. And so she can share the word with our community.
As I mentioned at the beginning of the discussion, I'm a pharmacist and a very proud member of a healthcare team. What would you say, or what would you recommend to other members of the healthcare team, like pharmacists, nurses, et cetera, who also care for these patients? What messages would you like us to focus on?
Well, I would say before focusing on messages, and I know Dr. Fergie mentioned that, is get the correct information. Right now we're in Texas, we're talking about Texas outbreak. I went into the Health Human Services, and I don't spend a lot of time on that because I'm fortunate in my hospital that I have an infection control department who's always sending me emails and saying, hey, this is what's going on. I couldn't find anything there. Obviously, I didn't spend a lot of time. So I think the first step is for all the healthcare team providers is get the information from a trusted source that is reliable, and then share that with the people you're coming in contact. And again, there's so much hesitancy, so don't be like in their face. Kind of just take time and tailor your message to whoever you're talking to. It's going to vary.
Great. So Dr. Gaeta, I'm going to continue with you. Are there lessons that we can apply from the COVID pandemic to ensure accurate information reaches at-risk populations?
Yes. So, I never thought that we would be talking about measles and saying, oh, COVID is done, and over with. So definitely the lessons learned, which I've kind of alluded to, is getting the correct information. I belong to a grassroots organization, where we were out there, talking about COVID vaccine, getting people vaccinated and having the health fairs. I think now what's unfortunate is now we're going to have to add another layer is it's hard to get that information, get reliable. So it's, we're actually looking at where can we go to a resource place? Maybe NHMA could be a depository where it's here is the reliable information. And then, get people to go there. I also speak with the migrant community health networks. So those kind of organizations, they could serve as deposits of reliable information, make it easier. Right now, I did go onto the CDC website. It's there. How long it's going to be there, I don't know. So it's kind of trying to be updated.
Dr. Fergie, would you like to respond to that question?
Well, I think you mentioned other healthcare providers, and it's a team effort. And, and our listeners know that many times physicians don't spend as much time with the patients as they want to. We have limited time. The nurses, the assistants in the office are key. And some of you may have experienced this, that sometimes the question goes to the nurse instead of coming to us, or maybe both. But there may be a very strong relationship with your nurse in your office. And that is key, actually. That person there has tremendous influence on the child getting vaccinated. Pharmacists at the community level, they are, they can provide vaccine. I know there are some issues, some restrictions according to the age, but there's so many vaccines they can provide and can help with this effort. So it's it's all of us who have to work together. I think that there's nobody like more important. Everybody is involved in this, and we just need to keep working on this.
Thank you. And this question, I'm going to stick with you, Dr. Fergie, and this one came in. What are some measles symptoms that can be confused with symptoms of other diseases?
Dr. Sam, that question I like it for a reason, and that is that one consequence of this outbreak is that now we are all worried about this illness. So we are beginning to overdiagnose this. We're beginning to get too concerned. I work at the Children's Hospital. I already seen it. So my colleagues in the ER are calling me and saying, oh, this child may have measles on the other one. And then we're admitting this patient. A problem is, and I'm not answering your question, but it's just, the problem is that there's no rapid test like COVID. That we took for a while to have the rapid test for COVID, and it was great. Well, there's not such a thing for measles. The ideal test is a throat PCR, but you have to take it, swab it, and send it out to the state or to a commercial lab. And in the meantime, you don't know. So look, measles has cough, coryza, conjunctivitis. Those are the 3 C's: cough, coryza, and conjunctivitis, and high fever. Well, those of you who work in pediatrics, you know very well that a common complaint of children that come to the ER or urgent care or your office is that they have fever and they have a rash. Some of them may have a red eye too, but most of them has a viral infection, not measles. So yeah, it can be confused. That's a problem. It can be very confused. So you have to be, so what I'm telling my colleagues right now is, look, is there travel history? Is a history that they were potentially in contact with a case, number one. Number two, is your patient vaccinated? 1 dose of the MMR vaccine provides 93% protection against measles. 2 doses, 97%. So take that into consideration before you make your diagnosis. If the patient is fully vaccinated, has not traveled, there's no measles in your community, then very, very, very unlikely that is the case. Patient is, just came from visiting a relative in the plains where there are cases, and is unvaccinated, and it has developed high fever, and it looks sick, and the patient has the rash. Then the problem is the rash appears a few days later, 3-4 days later. So it can be, I cannot blame anybody for confusing this. And the other problem is this: who has seen it? I have seen measles. I did my medical school in Latin America. I saw it. But many of my colleagues who are listening today have never seen it. And that's a wonderful thing. But on the other hand, it's a problem.
Dr. Gaeta, would you like to respond to that question?
Yeah, so in the adult population, immunocompromised, it's even harder because some of our patients may not even have the symptoms, the ones that are really compromised. But like Dr. Fergie said, my patients come in with a high-grade fever, cough. I'm thinking, is it the flu? Is it RSV? Is it an upper respiratory infection, neutropenic fever. So it's very hard. Unlike Dr. Fergie, I have not seen a measles case. I would have to get my book for the rash to see what that picture is. But I think a high suspicion, and it was interesting. I looked at an article that was published in 2000. It talked about, travel history, which Dr. Fergie mentioned. And it said, Japan, Israel. Well, unfortunately here in Texas, we would have to include, the Gaines area where they found the cases. So it's not just thinking of further out, but, in the local area, in New Mexico, Alaska, kind of ask that history.
So this question is for both of you. Feel free to respond. But I want to get at the root cause of some of this stuff. So what are parents saying as to why they don't want to vaccinate their children? What are some misconceptions that you're hearing? And what can we say to our community?
I'll let Dr. go.
I'll let you go first, and then I'll.
Well, I was going to say, so children, I'm an adult internist, and so I see adults. So my information is more from what's out in the social media, which again, I don't know how reliable it is, but I think, again, lessons learned from COVID, there's a group of population that is saying, COVID was fake, even till now, even when you show them that, look how many people died. And so that is what, they're using that information, translating and saying, let's not get measles, mumps, or rubella, vaccine. And then, of course, it's a religious thing. Or, I'm going to keep my kid for homeschool, so I don't need to have them do that. That's what I hear, but I'm not an expert in pediatrics. That's why I was going to defer to Dr. Fergie.
Well, Dr. Gaeta, thank you. I agree with what you're saying. So one thing that something that was particularly bad for the MMR vaccine was a fraudulent study, a completely corrupt study that came out many years ago in The Lancet. That is a prestigious journal. And but it was it turned out that the whole thing was corrupt. And they were saying that the vaccine was associated with autism. That has not, it's totally unfounded. It's totally false. There's multiple studies and analysis, and it's nothing to it. But it's still in the background, in the minds of many people who think that the vaccine is related to some side effects. So that's one. That's a big one. Another one, of course, the issue of some people are confused about the fetal cells that are used in the manufacturing of some of these vaccines. They don't understand that this is something from the 1950s that was just a cell line, that it was never was an abortion procured for vaccines. That never happened. Now, there were babies who were aborted in 41 or 2 in the 1950s or early 60s, and some of the cells were used and propagated. It's a very technical issue, but family need to understand. And I personally, of course, a pro-life person, I understand their concern, but we have to tell them, no, they have nothing to do with any concern about any abortion right now. So that's one thing that I have dealt with in the past. That I think is important. And then there is a whole movement of people who think that natural illness is better, that you should get infected. Remember the chickenpox parties. Now people are talking about measles parties. That just crazy ideas. So I mean, there's so many situations here, and they're losing. The other traditional problem with this is that they haven't seen the illness. They have no idea. So they hear about the vaccine side effects, but never heard about the illness. So now the young families are afraid of causing harm by giving a vaccine that is very safe. Tough. It's a tough job for all of us, but we are working.
It is a tough job for all of us. Let's move on to a little bit more controversial topic, because as you know, currently we're having information from reliable sources like the CDC being taken down. We are seeing different information from coming from places that we normally wouldn't get information from, like Facebook and YouTube. What are some sources of information that we can have our patients turn to with reasonable reliability and trust?
Well, I always say that, and I hope this doesn't change, despite what is going on, that the CDC had traditionally been a very reliable source of information, solid, scientifically valid source of information. And I know that there are some issues going on right now, but I am actually somewhat, a little bit reassured by the most recent statement from Health and Human Services Secretary that seem to be now telling people that the vaccine is key to control this outbreak. So I'm a little reassured from that point of view. So the other place, of course, I always tell people to go to is the American Academy of Pediatrics, AAP. NHMA, of course, is a good site, but AAP, the Infectious Diseases Society of America, is a reliable site where people can go. Obviously, and there are many of our medical organizations, Society for Adolescent Healthcare Medicine. There are so many of these societies that are, going to provide you with solid information about vaccine for, particular group of patients. AAP, of course, American Academy of Family Practice, is another very good one where you can get excellent information. And this is not an all-inclusive list.
Dr.
Gaeta, do you have any additional sources?
I would add the American College of Physicians, which is the internal medicine group, along with what Dr. Fergie mentioned. And then again, go back to your primary care doctor. I mean, that's your trusted physician who's been taking care of you and your family. Go to them, get information from them, ask them the questions.
Wonderful, wonderful. One more question before we depart and go back into this controversial subject. Something that came up is if you're an adult, Dr. Gaeta, and you've not been vaccinated, is it too late to get vaccinated?
A good question. No, a short answer is no, but it has to do based on how old you are, what vaccine you got, and then also one of the things that is recommended is if there's concern, if you're not sure if you have immunity, is to get a titer. Go to your primary care doctor and get a titer and see if your numbers are there. But then again, the titer, and I'll defer to Dr. Fergie because he's the expert on infectious disease. Just because you don't have a titer doesn't mean you're not immune. And so it's always like anything else is risk benefits, who, what kind of medical problems do you have, who are you going to be in contact with, and individualize the answer to that particular person.
And I assume the same question for the pediatric population, Dr. Fergie. If you haven't been on your schedule, it's not too late to get on the schedule.
No. I mean, we do have what's called the catch-up schedule. So if you didn't get it at the right time, just get it. And actually, the routine schedule is this. You get it one dose at age 12, 15, and then second dose about age 4 to 5. But if we go into a bad situation, hopefully not, but if we go into a really serious situation in wherever you are working, then you have a couple of things that you can do. Number one, you can reduce the interval because the valid interval is just 4 weeks between one of those two. So that if you're in the middle of an outbreak, you may just shorten the interval and give the second dose a lot sooner. Second thing that we can do with the MMR vaccine, if we need to, is to give an extra dose at 6 months of age. That provides some protection, but it does not count. So you still need to get 2 more. All right. So those are things that we can do. But yeah, there's the catch-up schedule. We can give it whenever we can if the patient has not received it. We are accustomed to this in pediatrics now with the migrant population. We have to give a lot of vaccines completely out of the schedule, completely out of the routine schedule, in order to take care of the people who come with no records of immunizations.
This is a message for our audience. I'm about to ask our last pre-planned question. So if you have questions, please start putting them into the chat, or if you'd like to ask it yourself, we can raise your hand and I'll call you in order. So Dr. Fergie, I'm going to go to you for this one first. How do you, and you did allude to this a little bit ago, but how do you grade HHS's response to this outbreak so far? Is there anything you'd like to see that is not happening?
Well, from the national level, from HHS, I would like to see a little bit more, a stronger message I mean, again, as I mentioned before, I'm encouraged that there was first it was a lukewarm, like this is, this happens all the time. And truly, I mean, it has happened all the time that there are little outbreaks, but not of this magnitude. It was 2019 when we had this magnitude of outbreaks. So just calling out the urgency of the situation, and emphasizing the importance of vaccination, and emphasizing the issue of safety of the vaccine, so people get reassured that these vaccines are very safe. And by the way, now they are in the market. There are 2 MMR vaccines. For decades, we only had one brand. Now we have 2 brands. Both of them are excellent. So if we could get a little bit more of a stronger message, that'll be good.
Dr. Gaeta, would you like to respond to that question?
Yes, and I have to just put a disclaimer. This is my opinion. I don't represent the University of Texas MD Anderson. Got to just put that out there. I think, like Dr. Fergie said, I was, just on the website, and it was good to see that there's an op-ed from our department secretary on March 2nd saying, call to action. So that was reassuring. My only concern is, I'm glad it's there, but we should have had it out there. I mean, because we've been hearing about the measles outbreaks, especially here in Texas, for a while. And it's like, I'm glad it's there, but have it earlier and reliable information, because what happens is you start hearing these numbers and people get scared. And then, how do you react? And you try to go look for the source of information and it's not there. So that would be my comment.
We have a number of questions from the audience, and I'm going to read them to you in order. But please feel free to continue putting them in the chat. Si quieren hacer preguntas en español, nuestros invitados hablan español y pueden facilitar sus preguntas. So let's go to the first question. So what is the current recommendation for young children aged 18 months to 4 years who have received the initial dose? Should they get a second dose early?
So I was addressing that issue a moment ago. I don't want to. I don't think it should be one person. Like, it shouldn't be me saying, "Let's do it. Let's go ahead and do it right now." I think they should come from the Texas Department of State Health Services. At some point, if we see this outbreak spreading, or we're there, for example, in Gaines County, they may be doing it already to bring down the interval. But I would not at this point suggest that we change the interval unless you are seeing in your community cases. And then I think you can bring the second dose much sooner, up to 4 weeks after the first one.
I'm going to jump down to the most recent comment here, because I think either one of you can answer this, but it says, please explain the titer not showing an existing immunity.
Well, sure. It turns out that there is cellular immunity that you cannot measure. Well, you can measure, but it's very complicated to measure cellular immunity. And because somebody who has received 2 vaccines may have memory T cells, even though they are not producing antibodies at the time you measure them, because the incubation period is relatively long, the person who is exposed to the measles and get the virus, their own cells will then begin to kick in and stimulate the plasma cell to produce antibodies. So all of that to say that even though you may not measure antibodies, you're still likely protected. And that's the reason that one of the ways we, in general in the community, we accept protection, or we consider a person protected if there is history of that person having received 2 doses of the vaccine.
Dr. Gaeta, would you like to respond to that?
Yeah, I agree with what Dr. Fergie, and I would just add, again, looking at the adults, population is potentially the immunity can wean over time. And so then it depends on when the titer's collected, is it done appropriately? It could give you a false negative. And so again, I encourage, it has to be individualized. Talk to your primary care doctor, say, this is my medical problem. Obviously, your primary care doctor should know your medical history, and this is where I'm at, where my exposures are, what my risk, and then make a decision based on risk and benefits. And then I think, reiterating what Dr. Fergie said, the MMR vaccine is safe. So if there's any doubt and there's any risk, get the vaccine.
Great. And I want to thank Leah Gabriel and Sara Mizani for those questions. This next one comes from Maria Byrne. CDC's website states that breakthrough infections, when someone becomes infected after they have been vaccinated, can occur, especially in communities experiencing an outbreak where high levels of measles viruses are circulating. How can I protect my child who is vaccinated? Will boosters be available?
At this time, there's not a recommendation for any additional doses. There's never really been a recommendation. Again, at least 97% protection with 2 doses, and of course, that leaves you 3%. But usually it's a mild illness in those people who get it. So at this time, I don't feel that I can make a recommendation for a third dose on my own, for this situation. So far it's just 2 doses.
Okay. Anything to add, Dr. Gaeta?
So not necessarily about the booster, but I think, how do you protect your child? Lessons learned from COVID, hand hygiene, this is an airborne. So if someone is coughing, you try to, be away from that, which is sometimes it's hard, distance, but physical distance, wash your hands. The virus can last in the airspace for 2 hours. So if someone's been coughing, sneezing, you might want to, protect yourself in that regard.
Okay, I have a clarifying question. So for the question above regarding recommended dosing schedules and or boosters, what's the current recommendation, especially for those who are based in an outbreak area? So are you saying there's no different recommendation for those in an outbreak area versus those who are not?
So the recommendation will be in an outbreak, or for people who are traveling to a part of the world where there is extensive transmission of measles, is to give the first vaccine, give an extra dose at age 6 months. Right, so that is a recommendation. But what I'm saying is, for the statewide, I don't feel that I should make that recommendation. That recommendation should come from our authorities in Texas, to begin saying, hey, in this area, you should begin giving the dose of 6 months. I would say, for example, Gaines County and that area, maybe they should be doing that, to give a dose of 6 months to these people. But keep in mind, that dose is extra. It's not really the first dose. It's an extra dose, and then you have to give another dose 12 to 15, and then your second dose of 4 to 5.
So this next question comes from Neraida Correa. Can we address the issue of herd immunity?
Sure. That's where, look, from all the viruses that are out there, measles is probably the worst in terms of reproductive number. It's about 18. It's huge. So look, if a person has measles and is in a household or in a place where people are not immune to the virus, more than 90% are going to get sick with this. Super easy to transmit. Boy, it's the worst. You think COVID is bad? This is way worse than COVID in terms of transmissibility. Way worse. So we need that herd immunity. The herd immunity means that, about 95% of the population is protected, so that there are not enough people to allow the transmission of the virus. It will die. In a community which has 95%, the virus will not continue transmitted from person to person. And if I can add something that I want to say before, remember, in the United States, we reached the status of elimination of measles in the year 2000, once we went into 2 doses of the vaccine. Very interesting, but that doesn't mean that there's no measles, obviously. But hey, we need to be careful not to lose that status. If this thing continues to go down, we're going to move back into the 20th century again with this situation. But we did really, really well for a time.
Oh yeah. Dr. Gaeta?
I agree with what Dr. Fergie said. The only other thing I would say is that, again, focusing on our immunocompromised patients, if they get the measles, they could be shedding for a prolonged period of time, and they may not even show the symptoms. So again, how do we prevent this is, get vaccinated if you're not, as a child, and then of course, as an adult, if you're behind an immunization, get vaccinated, because we need to get that herd immunity, 95% or greater.
Wonderful. This next question comes from Alea McKenzie. Piggybacking off the topic of fear or risk of an ICE encounter while seeking care, especially at our federally qualified health centers, How are other jurisdictions providing guidance that protects those who are at risk for more than just contracting measles? We're not just facing hesitancy with vaccinations, but also a lack of trust with government agencies, and that is a huge barrier to the work that needs to be done.
So I kind of missed part of it, but I think the question is, immigrants and, the whole ICE, because we have that executive order where before schools, hospitals, and churches were protected. So now, ICE can come to the hospitals. What I've lectured on and what our institution has done is, one, as a clinician, I don't document that the patient is unlawfully present. And I reassure them that even if I were to show up to my hospital, I'm not going to say, here, here's Senor Jose, here. I'm not going to do that. They have to have a warrant. But I understand that there's a fear there of going to the clinic, going to the hospital. Use what we've always done in our community. We have our health fairs. Go to the fields, have a health fair there, bring the information, bring the vaccines there. Go to the churches. I mean, go where the people are safe and comfortable, that they, are okay, and meet them there.
Great. Dr. Fergie, do you have anything to add to that?
No, nothing more on this point. I mean, I understand there's the fear issues, but I think I fully agree with Dr. Gaeta's approach on this.
So this next one is from Judith Flores. We need information in Spanish. So besides NHMA, what are some good resources that you know of for Spanish-speaking individuals?
I was at the CDC website this morning. I see the information in English, Spanish. However, I have not read the Spanish. So I would say start there, but I need to look at it and see, is it really readable? Is it at the 6th grade level? The typical things that we use. So I would say that would be the first place, but I have to look at it and see how reliable it is. Our communities, I work at MD Anderson, so we have a little bit different patient education departments, but at the community clinics, I assume that they have something there in Spanish, but again, I would ask what's available.
Great. Dr. Fergie, anything to add?
No, nothing more in particular. I agree with this, with her position.
Okay. This next question comes from Karen Szymanski. So it says, I've heard different recommendations on the news for those that are adults or older that may have had only one of the vaccine in the series. Some say that one is enough in an outbreak, and others say get second dose and ask your doctor if you're unsure. What are your thoughts on that? I'll start with you, Dr. Gaeta.
Definitely, I agree. Ask your doctor, given their history. Again, looking at the age population, if you were between 1963 and 1967, depending on what vaccine you get, you may need an additional immunization. The titer, going back to our cancer patients, we do a lot of treatments that, wipe out their system. We're doing research, and some of these new protocols, we don't know what it's doing on the immune system. So again, find out and get information from that, from your physician, your oncologist, to say, am I at risk? And more importantly, for the immunocompromised, can I get the vaccine?
Yeah. And, one thing I would add is, remember, there's no harm in giving another one. So if there's only one and you have any concern, you're not going to harm anybody by giving another dose.
However, sorry, Dr. Fergie, except for my immunocompromised patients or stem cell transplant, if they get the vaccine, they could actually get a vaccine-related measles. So again, again, depends on where they are in their treatment.
Absolutely, no, absolutely. I fully agree with that. I was not thinking about the immunocompromised. This is maybe it's a time to just mention this. This is a live virus vaccine. Yeah. So this is one in which we're concerned during pregnancy are immunocompromised. Children sometimes, for example, those who receive prednisone, for more than 10 to 14 days and more than 2 milligrams per kilogram. So there are certain categories there in which we cannot give the vaccine. And that's another point, that it's just in the importance of maintaining herd immunity, because there are some people who cannot receive the vaccine, and the only way to protect them is by herd immunity.
So talk to your care provider.
Yeah.
So these next two questions involve very young infants and or people who are pregnant. So do you think, and this comes from Anna Pentler, do you think maternal antibodies from vaccines are not as strong during pregnancy than if the mother has measles herself?
Right, that's interesting. So if the mother we know this, if the mother had measles, but of course we don't have that, almost nobody, then the antibodies are higher, and they're more transferred to the baby. But the mother was vaccinated, she will still transfer some antibodies to the baby.
Okay, great. Anything to add, Dr. Gaeta?
No, can't.
This next question is from Claudia Ramirez. Please provide tips on how to protect babies under 6 months who can't yet get the vaccine.
Immunoglobulin. So they need to get IgIM, and that will protect them. And you want to get immunoglobulin within 6 days of exposure.
Okay, so that's a really important point. So not prophylactically, it's post-exposure. Yeah. Okay.
It's post-exposure. You give for 6. And the other thing is, in somebody who is over 6, somebody who is over a year, let's say, and is exposed, you can give the vaccine within 3 days of exposure, and that is preventive.
So Dr. Gaeta, you mentioned earlier about immunocompromised individuals. How do we protect the immunocompromised after exposure?
After exposure?
That's correct.
Oh, well, after exposure, if they're immunocompromised, I would say go see your primary care doctor, call them and say, hey, I was exposed, and it's going to be a lot of how long were you exposed? I alluded earlier that the virus stays in the airspace for 2 hours. So, if you're in a room more than 2 hours, close proximity, and that person's coughing, sneezing, and also, does had the measles, again, with the caveat, if you're immunocompromised, you could sit longer. So that would be the first thing, is stay away from people, which I know lessons learned from COVID, there was research coming out afterwards that, isolation, stuff like that, but it's risk and benefits. As far as if you're exposed, I would say reach out. I don't have any information, but I can look for that to see once you're exposed as far as treatment or prophylactic, which I'm not aware of, but I can look.
Thank you.
It is possible, if I can answer, it is possible also to give some immunoglobulins, and it can be IV in some situations, depending on the level of immunocompromise. So that may help. But again, I think it's really important. It's something you need to discuss with your physician, particularly if you have an immunocompromising situation. You need to talk to your oncologist, your rheumatologist, nephrologist, whoever is taking care of your problem.
I think we have time for a couple more questions. I'm going to take us back a little bit to the previous discussion about ICE. So this is from Mary O. Escamilla. Expanding on the question about ICE raids. Is it judicial warrants that are required for allowing ICE entry into facilities? If not, is it an administrative warrant? Would you know?
So right now, the executive order is that ICE can come to churches, schools, and hospitals, what used to be protected. So they can come in, but if they say, I need to see you, if you have any unlawfully present individuals here, you say, no, I need to see your warrant. So they actually have to have a warrant, and it would have to be specific. In our institution, my first call would be called legal, and they would come down and, and deal with it. That is my institution. Other institutions have different policies. A good website, and for people who want more information, you guys can give them my email address, because I lecture on immigrants and health, there is for the emergency center, there is how to get prepared for, an immigrant care in the emergency center. And so I could give more references on that. So hopefully that answers the question.
And then this will be probably our last question before we close up. But regarding question about tips on how to protect babies under 6 months who cannot get a vaccine, are any of the current cases in babies coming from babies aged 6 months or younger? This is from Anna Pentler.
Well, the information that Texas is giving us, the Department of State Health Services, is only breaking down 0 to 4 years of age. And up to February 28, there were 46 in that category. So I don't know how many are younger than 12. Younger than 12 months.
All right, I think we're at the end of our questions, if I'm saying. Yeah, good job. So thank you, Dr. Fergie, and thank you, Dr. Agata, for your expertise and invaluable insights. This discussion underscores the urgency of raising awareness, promoting vaccination, and ensuring that our communities, especially our children and vulnerable populations, are protected from measles. Muchas gracias a nuestros invitados, al público, por asistir en este evento. To our attendees, thank you for joining today's town hall. NHMA remains committed to providing timely and relevant information to support healthcare professionals and the communities we serve. Please stay engaged, follow NHMA for updates, and become a member. I'm urging you, I'm asking you to give us a shot again. Become a member of NHMA and help us advocate for immunizations and preventable healthcare. Join our movement for the health of our communities. This concludes our session. Have a great day, stay safe, and I hope to see you all in Anaheim, California for a June conference. Thank you.
Thank you very much.
Thank you.
Bye-bye.